improved processes sizing and outcomes compared to TE or a transthoracic or 2D transesophageal echo. Using the spine line method with manual placement of segmentation points that are automatically connected by SP line interpolation is the most accurate method compared to freehand attenuation or house fill based or polygon techniques. Aortic valve annular rupture is a rare event, but it is catastrophic when it occurs. The risk factors have been identified, such as small aortic valve annulus, small aortic root, aggressive processes oversizing, using balloon expandable TAVR decides compared to self expandable devices. Protruding subannular calcifications, especially non coronary cusps and LVOT. Because most patients undergoing TAVR have a high aortic valve calcium burden, measuring the annulus should be standardized to avoid measurement errors and post-TAVR complications. The annular counter should be measured along the tissue blood interface with focused attention while measuring to draw the counter in a consonant fashion, regardless of the presence of calcium. One practical tip to improve the measurement reproducibility is to draw the annular counter as if the calcification did not exist. Ascending aorta. Defining the geometry and anatomic categorization of the aorta is required in severe aortic stenosis patients undergoing TAVR evaluation to prevent serious complications including coronary artery obstruction, occlusion, device embolization, or annular rupture. The 3D CT aortogram can also provide two important fluoroscopic angles for TAVR implantation. One that is coplanar and equidistant to the three cusps, that is a right, left anterior oblique or angle, in which the non-right and left bisecting the right coronary cusp. And one that overlaps the right and left cusp is the right anterior oblique angle, in which the cusps overlap the angle bisecting the non-coronary cusps, this isolates the non-coronary cusps and is important particularly for self-expanding valves to avoid lower implantation and membranous septum contact and subsequent risk of new pacemaker implantation after the procedure. In addition to the aortic measurements, CT can help predict the optimal angiographic angle during TAVR. In contrast to surgical aortic valve replacement, where the calcified native aortic valve is removed and replaced with the surgical processes valve in patients undergoing TAVR, the native leaflets are pushed by the TAVR valve, which may lead to coronary artery occlusion. The high-risk anatomy is the lower coronary ostial height of less than 12 mm, sinus of valsalva diameter of less than 30 mm, and STJ height of less than 15 mm. In addition, length of the aortic valve cusps and the degree of calcification are important anatomical considerations and ought to be reported prior to the procedure. Evaluation of the access sites. Despite the advancement of TAVR's devices, delivery systems with a reduction in their size, vascular complications remain a major source of post-TAVR complications, including the length of hospital stay, morbidity, and mortality. Therefore, pre-procedure planning and evaluation of the vascular tree are important to aid in choosing the appropriate vascular access and predict the risk of vascular complications. Risk factors in determining suitability for femoral access includes significant circumferential or horseshoe-like calcifications, the luminal narrowing of less than 6 mm, severe vessel torsity, common femoral artery, high bifurcation, anterior wall calcifications, and focal stenosis. The alternative access include transcarotid, transaxillary, or subclavian access. Stroke rate for some of these alternative types of access might be higher than with the femoral approach. Randomized trials comparing different access sites in TAVR patients are still lagging. Importance of assessing the suitability of carotid emboli protection devices prior to TAVR. Stroke remains a concerning complication in TAVR patients, although it has significantly improved from previous experience. To date, carotid protection devices have not shown a reduction in the current rates of silent or clinical cerebral ischemic lesions or a decrease in mortality. But studies have shown a reduction in the total cerebral ischemic volumes that could affect long-term outcomes and quality of life, especially for younger patients who are considered low surgical risk. Therefore, suitability for these devices should be assessed, including aortic arch vessel anatomy, vessel diameter, and calcification. Evaluation of coronary arteries and coronary bypass grafts. Given that nitrate usage has traditionally been relatively contraindicated in severe AS and additional beta blockers have not commonly been administered prior to TAVR and CTA, the quality of the coronary arteries evaluation may be affected in these severe aortic stenosis patients who typically have a greater burden of coronary calcification and atherosclerotic plaque. A recent pilot study using selected patients undergoing a pre-TAVR CT examination with the use of nitroglycerin, beta blockers, and CT fractional flow reserve showed its safety and diagnostic accuracy for coronary artery diseases. Evaluation of bypass grafts is typically easier because they tend to have lesser movement and large caliber. CT scan is also helpful in identifying different coronary artery anomalies that are considered either high risk or prohibitive for TAVR instead of SAVR. The risk factor for coronary obstruction with valve-in-valve transcatheter aortic valve implantation. These are anatomic factors, bioprosthetic valve factors, and transcatheter valve factors. Anatomic factors are low-lying coronary ostia, narrow STJ with low sinus height, narrow sinus of Valsalva, previous aortic root repair. Whereas bioprosthetic valve factors are supraannular position, high leaflet profile, internal shunt frame, no shunt frame, bulky leaflets. Transcatheter valve factors, extended sealing cuff, and high implantation. CT evaluation of valve-in-valve TAVR, sizing. Although surgical information may be available from patient records or the surgical valve card, TAVR CTA reconstruction allows for confirmation, correction, or generation of the SAVR data. The shunt frame morphology and measurement of the basal internal diameter of the SAVR processes can be verified by referring to the valve-in-valve app. Risk of coronary obstructions is more for valve-in-valve TAVI. Risk assessment for coronary artery obstruction for valve-in-valve transcatheter aortic valve replacement. Type and size of the implanted valve are known. This is estimated by CT morphology and diameter. If it's a standard surgical valve, similar assessments with TAVR in native aortic stenosis. The level of the coronary ostia should be below the stent post. No risk. The indicates no risk of occlusion or no further assessment. The sinus junction should coronary ostia should be at least less than if it is less than 4 mm, then there is a low risk of coronary occlusion. Then high risk. It also has high risk of occlusion if it is less than 4 mm. CT assessments in patients with bicuspid aortic valve. Presence of the prevalence of bicuspid aortic valve is 1 to 2%, of whom up to 50% of patients require surgical intervention. The bicuspid aortic valve is up to 3% up to 3% of patients undergoing TAVR. The identification and categorization of bicuspid aortic valve carry considerable importance, and societal guidelines recommend comprehensive assessments of the valve morphology in TAVR, planning for patients with bicuspid aortic valve. Sievers classification has conventionally been used. CT assessments in patients with bicuspid aortic valve. Recently, a TAVR-directed and simplified bicuspid aortic valve classifications has been proposed. Using these morphologies according to the number of commissures and the presence or absence of raphes. The first one is a dry commissural, in which one commissure completely fused between the two cusps, often referred to as a bifunctional or acquired bicuspid aortic valve. Bicommissural raphe type, two cusps fused by a fibrous or calcified ridge, equivalent to sievers of type 1. Bicommissural non-raphe type, two cusps completely fused from their basal origin with no visible seam, equivalent to sievers type 0. This is a picture showing the classification of bicuspid aortic valve. Sievers type 1, 1B, which is sievers type 1, and 1C is sievers type 2. Tricuspid, whereas 2A is tricommissural bicuspid, 2B is bicommissural bicuspid with non-calcified leaflets. High risk features. There are several unfavorable features of bicuspid aortic valve anatomy for the TAVR procedure. One, when it is very elliptical or eccentric annulus, asymmetric calcium distribution, bulky calcification extending into the left ventricular outflow tract, low coronary ostia height, short sinus of Valsalva height, and ascending aortic dilatation. A shows the elliptical annulus, B shows higher calcium distribution, Third picture shows the bulky calcification extending into the left ventricular outflow tract, and fourth one is the ascending aortic dilatation. Stepwise approach to the transcathetic aortic valve replacement. First one is a procedural setup, vascular access, assess the coplanar angle, aortic valve crossing, balloon pre-dilatation, valve deployment, and post-TAVR assessment. Procedural setup, anesthesia, general versus moderate anesthesia. Room setup, standard for transfemoral approach. Alternative access setup, depending on the access route, may need an additional table to facilitate position. Vascular access, the primary large bore access under ultrasound guided access, with confirmation angiogram, and plan for closure, which has devices per close or manta, which has two preloaded sutures within it. The secondary access is for the pigtail, which is placed at the base of the non-coronary cusp, and multiple iotograms are taken during the implant at an angle obtained from the CT iotogram. The placement for the temporary venous pacemaker with balloon tipped, best and safest practice. Sometimes neuroprotectional devices are also used. Assess the coplanar angle. Angiogram to confirm coplanar angle for deployment. Adjust as necessary. Aortic valve crossing. Use standard guides and wires for crossing. The exchange length wire to change the catheter for pigtail catheter. It should be connected to a manometer to measure the peak left ventricular and aortic systolic and diastolic measures are measured. This is because the end diastolic separation between the aorta and the left ventricle plays an important role in the assessment of paravalvular leak after valve implantation. Use of pigtail catheter to deliver stiff wire in the left ventricular apex, just above the apex, pointing away from the ventricular valve to avoid injury to the ventricular wall. The wires are two types. One is pre-shaping and one is fixed wires. Amplat's extra stiff wire is useful for S3 valve, whereas Lunderquist is used for stiffest. It is the stiffest wire in the market. Whereas the preformed wires are Confida and Safari. Balloon pre-dilatation, it is optional. Aortic valvuloplasty for pre-dilatation if needed, and it is performed at a rapid ventricular pacing of 180 beats per minute. And the conservative sizing of balloon aortic valvuloplasty, which is based on the minor diameter of the aortic annulus. Valve deployment, standard procedure based on selected bioprocesses. Two types of valves. One is balloon expandable, one is self-expandable. Balloon expandable, the valve is loaded on the balloon in the aorta, advance, deploy in a coplanar angles under rapid ventricular pacing. Whereas in a self-expandable bioprosthetic valves, the cusp overlap technique increasingly used for deployment. In the post-TAVR assessment, completion iotogram, post-TAVR invasive hemodynamics, transvalvular gradients, diastolic gradient and left ventricular end diastolic pressure are monitored. Whereas in an echocardiographic assessment, transvalvular gradients assess for the perivalvular leaks and aortic insufficiency and for any pericardial effusions, and a peripheral angiogram after access closure. The components of Edwards Sapien balloon expandable valve. It has two components, the valve bioprocesses and the valve delivery system. The Edwards Sapien valve is made up of bovine pericardial tissue from forming the valve leaflets, polyethylene terephthalate forming the outer skirt, whereas the cobalt chromium forming the valve frame. The Edwards Sapien 3 valve, which is the most recent addition, has an outer sealing skirt to decrease the paravalvular leakage. This comes in the sizes of 20, 23, 26, and 29 mm. The Edward Commander delivery system components include the following. One is the flex catheter, which aids the valve alignment to the balloon and tracking and positioning of the valve. And a balloon catheter has a taper tip and a radio-opaque valve alignment markers to delineate the working length of the balloon. A radio-opaque center marker to help the valve with valve positioning, and a radio-opaque triple marker proximal to the balloon to indicate a flex catheter position during the valve deployment. The handle contains a flex wheel to control the flex catheter, a balloon lock, and a fine adjustment wheel to facilitate valve alignment and position of the valve within the native valve annulus. Now, this picture shows the central markers, a triple marker, the flex catheter, and a balloon catheter, which helps in alignment with the annulus. Edward E. Sheath introducer, a low-profile sheath and a dynamic expansion mechanism that expands transiently during the passage of the Edward Sapien valve. It comes in two sizes, 14 French and 16 French. Essential steps: the Edward E sheath with the E logo facing up is advanced through the primary arterial axis under fluoroscopy guidance, and the tip of the sheath is parked in the distal part of the descending aorta above the iliac bifurcation. Heparin is given to keep the activated clotting time around above 250 seconds. Then a temporary pacemaker is advanced through the femoral vein axis to the right ventricle, and the pacing capture threshold is assessed. A pigtail catheter is then advanced through the secondary arterial axis site and placed in the right coronary cusp. At this point, the coplanar angle should be assessed and determined by root injections. The aortic valve is crossed using the Amplat's left catheter and straight tip wire. Judkin's right and or Amplat's right catheters may also be needed for aortic valve crossing. Once the aortic valve is crossed with a straight wire, the catheter is advanced to the left ventricle. The straight wire is then exchanged with a J-tipped wire, and a pigtail is advanced to the left ventricular apex. And the operator confirms no entanglement of the mitral chordae apparatus. Hemodynamic assessment is then performed to assess the baseline systolic gradients as well as the diastolic pressure separations. A pre-shaped extra stiff wire is advanced and positioned in the left ventricle. The loader at the tip of the valve delivery system is then inserted into the E-sheath. If the balloon aortic valvuloplasty for valve predilatation is needed, it is performed at this point with rapid ventricular pacing. Then the commander valve delivery system follows, with the Edward logo facing up through the sheath until the valve exits the sheath. Then the loader is retracted. The valve alignment of the balloon is valve alignment to the balloon is performed in the straight part of the descending aorta under fluoroscopy. The balloon lock should be disengaged first. After the balloon catheter is pulled straight back until part of the warning marker is visible on the balloon catheter. Then the balloon lock is engaged and the valve is positioned between the valve alignment markers using the fine adjustment wheel. The valve delivery system is advanced through the descending aorta, aortic arch, and ascending aorta to the aortic valve with a smooth continuous motion while flexing the catheter using a flex wheel. Once the bioprosthetic valve is across the aortic annulus at the appropriate depth, the balloon lock is disengaged and the flex catheter is retracted to the center of the triple markers. The bioprosthetic valve position is then adjusted as necessary using the flex wheel to adjust the coaxiality of the valve and the fine adjustment wheel to adjust the depth of the valve. The valve position between the valve alignment markers and the flex tip catheter position over the triple marker should be confirmed before valve delivery. The valve delivery is performed at the predetermined deployment coplanar angle. It is executed by inflating the delivery balloon under rapid pacing once the systolic pressure drops to less than 50 mm of mercury. The balloon should be inflated with the entire volume in the inflation device and held for 3 seconds before deflating. The rapid pacing is stopped once the balloon is fully deflated. After the valve is successfully deployed, the valve delivery system is slowly withdrawn into the descending aorta while maintaining the guide wire in the left ventricle. The catheter withdrawal is facilitated with unflexing of the delivery system while retracting it. Then the delivery system can be removed from the body. The post-implantation aortogram should be performed to confirm the bioprosthetic valve location, assess for any aortic insufficiency, and evaluate the patency of the coronary ostia. A pigtail catheter is also advanced into the left ventricle to assess the transvalvular pressure gradient and diastolic pressure separation. The transthoracic echocardiography also should be done to confirm the valve function and assess for aortic regurgitation, left ventricular function, and pericardial effusion. Components of self-expanding type of transcatheter aortic valve. Medtronic valve platform is a self-expanding type of transcatheter aortic valve. The system has two components. One, the valve bioprosthesis and the valve delivery system. The Medtronic valve bioprosthesis is made of a porcine tissue component forming the valve leaflets and a skirt on a nitinol self-expanding valve frame. The porcine valve leaflets are located in the supraannular plane. The Medtronic aortic valve platform has evolved from the core valve to Evolute Pro. The Evolute Pro, which is the most recent addition, it has a porcine tissue forming an outer skirt over the inside and outside of the inflow portion of the nitinol frame to decrease the paravalvular leak. The Medtronic valve processes comes in four sizes, 23, 26, 29, and 34 diameters. The Medtronic valve delivery system components includes the following. It has an introducer sheath of 16 French size inline sheath, radio opaque catheter tip, capsule covers the bioprosthetic valve and maintains it in a crimp position. And the capsule also has a distal flare that enables the bioprosthetic valve to be partially or fully recaptured after the partial deployment. It has a handle or a knob located at the proximal end of the valve delivery system, at valve delivery catheter, and which is used to load, deploy, capture, and reposition the bioprosthetic valve. Steps for self-expanding valve positioning. The preloaded valve in the capsule should be evaluated under cine fluoroscopy at 30 frames per second. The integrity of the valve, capsule, and paddle should be assessed. The valve delivery system is then loaded on the wire and advanced through the iliofemoral arteries, descending aorta, arch, and ascending aorta. Then the valve is positioned across the native aortic valve, targeting an implant depth of 3 to 5 The valve delivery is performed at a predetermined deployment cusp angle via counterclockwise rotation of the valve delivery knob on the handle. It should be done at a rapid ventricular pacing rate of 120 to 160 beats per minute during the initial valve deployment phase until the annular contact is achieved. The valve deployment is continued by counterclockwise rotation of the deployment knob until a tactile response is noted. This is a precautionary mark that indicates the point of no recapture is nearing. Once the point of no recapture is reached, once the radio opaque capsule marker band reaches the distal end of the radio opaque paddle attachment. Complications after TAVR, mechanical complications, non-mechanical complications. Mechanical complications include the annular rupture, perforation and tamponade, valve infolding, valve embolization, paravalvular leak. The non-mechanical complications include coronary artery obstruction, conduction disturbances, and stroke. Annular rupture, it is a term that encompasses a spectrum of procedural related injuries in the region of the aortic root and left ventricular outflow tract during transcatheter aortic valve replacement. The annular rupture can be uncontained or contained. If it is uncontained, with a frank extravasation can be seen, whereas it is contained, new periaortic hematoma can be visible. The region of the injuries can be intraannular, subannular, such as the intraventricular septum, supraannular, such as the sinus of Valsalva or STJ juncture, or a combined rupture that involves multiple anatomic areas. It occurs in about 1% of all TAVR procedure. In the largest cohort studying annular rupture, root rupture accounted approximately 2/3 of these cases, and periaortic hematoma 1/3. The annular injury and rupture may occur during multiple phases of the procedure, including balloon, pre-dilatation of the native aortic valve, prosthetic valve deployment, or valve post-dilatation for paravalvular leakage. The annular rupture is largely seen with balloon expandable valves, although there are case reports of rupture with self-expandable valves during post-dilatation of the prosthesis to treat residual paravalvular leak. Risk factors for annular rupture include 1. Post-dilatation, smaller annuli, narrow root, annulus eccentricity, chronic immunosuppressive therapy, heavy leaflet or annular calcifications, or sinus of Valsalva calcifications. In a large cohort of TAVR patients, moderate to severe left ventricular outflow tract or subannular calcifications and aggressive annular oversizing of more than 20% were shown to be the strongest risk factors for annular rupture. Moderate to severe left ventricular outflow tract calcifications were defined by 2 or more nodules of calcium, or one extending more than 5 or covering more than 10% of the left ventricular outflow tract. The overall in-hospital mortality is high, reported around 50%. The mortality rate considerably depending on whether the rupture is contained. In one of the largest series studying annular ruptures, all the deaths occurred in patients with uncontained ruptures with an overall mortality rate of 75%. Diagnosis: the presentation of annular rupture can range from asymptomatic to immediate hemodynamic collapse, depending on the location and the severity of the injury. The rupture should be suspected in the case of new onset pericardial effusion, hemodynamic changes, aortic wall thickening or dissection, hematoma between the aorta and the pulmonary artery, or a new intracardiac shunt, such as the ventricular septal defect. Intra-procedurally, through TE is a typically able to identify the annular rupture as well as characterize any associated paravalvular regurgitations. Post-procedurally, it is by CT or transesophageal echo can be used for surveillance. It is surgical management depends upon the type of rupture. If it is an intraannular, repair of the lesion with an aortic valve replacement. If it is subannular, it could be free myocardial or an injury to the anterior mitral leaf red or injury to the interventricular septum. And the treatment is as shown in the picture. Supraannular injury to the sinus of Valsalva, it can be injury to the sinus of Valsalva, coronary ostium, or the STJ. And combined, it can be intra or supraannular. Prevention of rupture. Identification of high risk factors for rupture is most crucial. Heart team discussion to decide TAVR versus surgical aortic valve replacement versus conservative management. If TAVR is decided, high left ventricular outflow tract calcification of more than 5 mm or 20% circumference should raise a concern. Avoid aggressive oversizing of more than 20%. It should be referred to a higher volume TAVR center. High valve deployment in case of heavy left ventricular outflow tract calcium, and consider self-expanding valves and avoid post-dilatation for mild residual leaks. Perforation and tamponade, it can result as a the result of perforation of one of three of the different structures. It could be due to right ventricular, left ventricular, or the aortic root. We already addressed the aortic root rupture. Cause of perforation in the right ventricular perforation is usually it is secondary to improper placement or manipulation of the temporary pacing wire. Whereas the LV perforation is secondly due to trauma to the step wire, whereas the LV perforation from delivery wire is likely more common with the use of pre-shaped stiff wire. The diagnosis and management. Perforation should always be suspected in the case of new pericardial effusion or hemodynamic deterioration of the patient. TE is able to characterize the size and hemodynamic consequences of the perforation. Right ventricular perforation can almost always be managed conservatively or with pericardiocentesis, rarely requiring surgical repair. However, in case of a posterior effusion, there may be difficulty to access from a percutaneous approach. If recognized early and managed with drainage, RV perforations usually have a favorable outcome and rarely need surgical repair. Prevention of RV perforation, it is likely more frequent with the use of screw-in leads rather than passive balloon-tipped pacing catheters. So screw-in leads should be avoided whenever possible. With balloon-tipped catheters, only overly aggressive wire manipulation in an attempt to achieve optimal threshold should be discouraged. This is particularly relevant in elderly patients and patients on chronic steroids due to the thinner and more fragile right ventricle. LV perforation. For LV perforation, management depends on the type and extent of injury, clinical status, and operative candidacy. In free left ventricular perforations, there is typically rapid hemodynamic instability requiring immediate initiation of cardiopulmonary bypass, sternotomy, and open repair. If there is a small left ventricular perforation, percutaneous drainage may be possible, but vigilant monitoring is required. In cases of left ventricular pseudoaneurysm, percutaneous plug placement and open repair are treatment options, depending on the size of the defect and overall operative candidacy. Left ventricular perforations with subsequent tamponade can carry a very high mortality, with the majority of patients dying in. Prevention of left ventricular perforations, these are typically secondary to the improper use of self-shaped or stiff support wires. The use of a dedicated TAVR wire, example Safari or Confida, is likely safer than self-shaped wires. If the operator chooses to shape wires, one should be diligent in ensuring an appropriate curve has been made. Bioprosthetic valve infolding. The prosthetic valve infolding is an uncommon complication seen with the use of self-expandable valves for TAVR. It occurs when the valve frame is infolded during deployment with secondary distortion and malfunction of the prosthesis. This was initially described in the first generation core valves, but it has also been reported in the Evolute R and Evolute Pro. The mechanism for infolding is unclear, but it is likely related to the low radial force of the nitinol frame. This is particularly relevant with large valve because they have lower radial force by nature of the design. Infolding can lead to severe paravalvular leak and intravalvular leakage with hemodynamic collapse owing to valve dysfunction. The infolding is also associated with an increased rate of periprocedural stroke, likely secondary to the need for further manipulation of the valve. The largest available case series, which included patients from 2015 to 2020 and included the first and second generation self-expandable valves, reported an infolding rate of 3.15%. More contemporary case series with only evolute are reported a lower rate of 0.7%. The risk factors for infolding valve include valve and patient-related characteristics. The valve-related characteristics that predispose to infolding of self-expandable valves include the resheathing and large valves of more than 29 mm. The patient-related risk factors include the bicuspid valves and heavy calcification. A diagnosis of infolding: if there is a severe paravalvular leak or hemodynamic instability after self-expanding valve deployment, valve infolding should be suspected. Signs of valve infolding can be seen on fluoroscopy, including a narrower than expected valve processes and a vertical line along the valve frame. The meticulous attention should be paid to evaluating the valve frame with multiple fluoroscopic angles or the cusp overlap technique prior to release. In addition, right anterior oblique cranial view, looking down the valve on the short axis, can confirm the diagnosis. On echo, the infolded valve is easily recognized, particularly on the short axis. This picture show the narrowing of the first picture shows the narrowing of the valve, and D picture shows echocardiographically Pacman sign of the narrowed valve. Management of infolding. In valve, if valve infolding is recognized prior to release, recapture and replacement with the new transcatheter heart valve is preferred. If this complication is not noticed until after valve deployment, immediate post dilatation is required to restore the valve function and avoid hemodynamic collapse. Typically, post dilatation can eliminate the infolding. If this is unsuccessful, retrieval and deployment of a new valve will be necessary. Whether there are long-term consequences to the valve after post-dilatation for infolding is unknown. Valve embolization. The term valve embolization implies permanent loss of contact of the valve processes with the native valve structure. The valve most commonly embolizes to the ascending aorta, but can also be in the left ventricle or the descending aorta. Migration of the above the heart valve can also occur, where there can be varying degrees of displacement within minutes or even days after implantation. In a large TAVR registry, transcatheter valve embolization or migration occurred in 273 patients, that is 0.92% out of 29,636 procedures. Of these cases, 20% trans heart valves embolized to the left ventricle, while majority migrated or embolized to the ascending aorta. In the lower risk partner trial, there were no reported cases of valve embolizations. Causes of embolization of the valve. Malpositioning is the most common cause, which accounted for more than 50% of the cases. Other technical causes are improper valve manipulation and the use of delivery catheter. One is significant valve undersizing and the failure of rapid pacing. The main patient-related factors, that is a risk factor for embolization, is a bicuspid valve with slightly higher rates of implantation of a second valve or conversion to open surgery. Causes and the treatment: high deployment, undersized processes, and rapid pacing failure. Usually, snaring with the balloon and anchoring in the descending aorta is the option. In a case of high deployment, undersized processes, post dilatation errors, no dislodgement, no disengagement of processes and delivery systems, snaring with lasso and anchoring in the ascending aorta. In low deployment and wrong annular splines, valve and van implantation, or snaring and pulling into the correct position. Whereas in a rapid pacing failure, undersized processes, and failure to pull the flex catheter off the balloon, the conversion to open heart surgery, snaring with balloon. Important points to remember is if the valve is embolized to the left ventricle, open heart surgery typically is performed for removal. If the valve embolizes to the aorta, it can be typically managed with percutaneous techniques. So pulling the heart valve back across the arch should be avoided whenever possible due to the risk of arch dissection or stroke. If the valve is typically pulled to an area of the lumen that is sized appropriately for the valve and does not compromise flow to important branches. After the embolized valve is deployed in a stable position, A second heart valve is implanted by traversing through the first valve and realigning with the annulus. Prevention of embolization. Given that majority of causes are technical, embolization can typically be avoided. Ensuring a stable pacing capture and position is crucial to avoid loss of capture during the valve deployment. Significant valve undersizing can be avoided by careful pre-procedure planning with annulus sizing by multi-detector CT. Good communication between operators and technicians and adequate training can avoid most issues with improper delivery catheter manipulation and technique. Strokes that occur immediately early in or in the first few days are commonly attributed to the embolization of procedural debris. Delayed strokes are considered those which are not detected immediately but occur after 24 hours later. And there is a debate as to whether they occur due to slow thrombus formation or simple delay in neuroimaging. From 7 to 30 days later is considered delayed and is typically felt to be related to patient factors. A novel challenge with respect to peri-TAVR strokes is the timely recognition of signs and symptoms of acute stroke due to sedation or anesthesia. Intra-op neurophysiological monitoring is an emerging tool for recognizing TAVR-related strokes. Acute reperfusion therapy, including systemic thrombolysis and mechanical thrombectomy, is the mainstay of acute ischemic stroke management treatment. According to American Heart Association and American Stroke Association guidelines, offers class 1A recommendations for thrombolysis of acute ischemic stroke in the 0 to 3 hour window time period, and for the mechanical thrombectomy for selected patients in the 0 to 24 hours time window. The guidelines do not provide any specific recommendations concerning TAVR patients. Data on acute reperfusion therapy for strokes after TAVR is limited. More studies are needed to optimize prevention and treatment strategies for acute stroke after TAVR. This is a patient underwent transcatheter aortic valve replacement and experienced severe stroke symptoms during the procedure. The patient was taken to the neuroangiographic suite for emergent angiography. Digital subtraction angiography confirmed left MCA M1 occlusion, and the patient received stent retriever based mechanical thrombectomy and high grade reperfusion was established. Coronary artery obstruction. The coronary artery obstruction as a consequence of TAVR is uncommon, with an incidence of less than 1% for native aortic valve in multiple case series and registries. In one of the large multi-center TAVR registries evaluating outcomes in 6,688 patients, 0.66% suffered symptomatic coronary obstruction. The coronary obstruction is approximately 4 times more common when performing TAVR as a part of valve-in-valve procedures. The increased risk is likely because most surgical processes are in the supraannular position, resulting in lower coronary heights relative to the valve leaflets, and because valve suturing draws the coronaries closer, decreasing the sinus width. For patient undergoing valve-in-valve TAVR, the surgically implanted valves with the highest risk of coronary obstruction are stented bioprosthesis with externally mounted leaflets, example Sorin Minfros, St. Jude Medical Trifecta, and in case of a stentless bioprosthesis, example Sorin Freedom, Medtronic Freestyle, and St. Jude Medical Toronto SPV. The stented bioprosthesis with internally mounted leaflets like Edwards, Perimount, and Magna, and St. Jude, they have a lower risk of coronary obstruction. Anatomic risk factors for valve-in-valve transcatheter aortic valve replaction causing coronary obstruction. Anatomic factors, bioprosthetic valve factors, and transcatheter valve factors. Anatomic factors are low-lying coronary astia, narrow sinotubular junction with lower sinus height, narrow sinus of Valsalva, and previous aortic root repair. Whereas bioprosthetic valve factors, supraannular position, high leaflet profile, internal stent frame, no stent frame, and bulky leaflets. Whereas transcatheter factors are extended ceiling cuff and high implantation. There are 5 potential mechanisms for coronary artery obstruction in TAVR. The most common mechanism is the displacement of the native or surgically implanted valve leaflet towards the coronary ostium, such that it blankets the ostium. The second is a sinus of Valsalva sequestration, which can occur by displacement of the native or surgically implanted valves and cause obstruction to the entire sinus in an aortic root with a low or narrow sinotubular junction. Third is a mass obstruction, typically by a calcium deposit on a native or surgically implanted valve leaflet that is deflected during TAVR deployment to obstruct the coronary artery. The fourth is a valve skirt obstruction, where the valve prosthesis reaches high enough that the skirt covers the coronary ostium. The final mechanism is embolization of thrombus or degenerative material in the aortic root or on the TAVR device to cause coronary obstruction. The first one is the deficient sinus, second one is sinus sequestration, third one is obstruction by mass, and the fourth picture shows the skirt obstructing the sinus. CT assessment of coronary obstruction with valve and valve transcatheter aortic valve replacements, coronary and bypass graft parameters, stenosis in coronary astia, and patency of bypass graft should be seen. Whereas aortic root parameters, sinus of valsalva diameter, and the sinus height. Bioprosthetic valve parameters are leaflet thickness, calcification, or pannus, and surgically implanted valve post height should be seen. Whereas bioprosthetic root relationship, sieving ring to the coronary ostial height, and the virtual transcatheter valve to coronary height should be less high. If it is less than 4 mm, indicates high risk. Treatment for coronary artery obstruction with TAVR, if no preventive strategy is employed, treating coronary obstruction from TAVR is a therapeutic challenge. Treatment strategies include percutaneous coronary intervention, emergency coronary artery bypass surgery, or valve recapture in the case of retrievable TAVR valves like Medtronic Evolute, Bostonic Scientific Lotus valve, and Abbott Portico. Preparatory coronary protection. In cases where coronary obstruction is a concern, preparatory coronary protection may be used, in which a wire and an undeployed stent are placed in the coronary vasculature. Should coronary obstruction occur, the stent can be pulled back and deployed between the TAVR struts and the aortic root to provide what is variably described as a snorkel, chimney, or periscope between the aorta and the ostium. While this technique has been employed successfully, the cyclic compressions and other vascular perturbations around the stent may lead to stent deformation or thrombosis with resultant late ischemic complications. Bioprosthetic or native aortic scalloping, intentional laceration to prevent coronary artery obstruction, basilica procedure. Illustration of the basilica procedure, a catheter directs an electrified guide wire that is through the base of the left aortic cusp into a snare in the left ventricular outflow tract. The free end of the guide wire is retrieved using the snare, and the mid shaft of the guide wire is electrified to lacerate the leaflet. The lacerated aortic valve leaflet splays after transcatheter aortic valve replacement, permitting the coronary flow. Paravalvular leaks. Indications for paravalvular leak closures: moderate to severe paravalvular leak with heart failure symptoms and classically significant hemolytic anemia. Contraindications for percutaneous paravalvular leak closure include: 1. Aortic valve endocarditis, regurgitation which is involving more than 1/3 of the circumference of the prosthetic annulus, an unstable or rocking prosthesis, and the presence of an intracardiac thrombus with risk of distal embolism. Paravalvular leak sizing by transesophageal echocardiography or by 3D CT reconstruction or device simulation on a patient specific 3D printed model. Device closure choices for aortic paravalvular leak closures, and a number of devices have been used to close the close paravalvular aortic leaks of aortic valves. 1. The Amplatzer vascular plug 2 is the most commonly used devices. It is circular and suitable for round paravalvular leaks, whereas type 3 devices Abbott are rectangular and can be used to occlude more crescentic shaped paravalvular leaks, and other Amplatzer devices like the muscular ventricular septal defect occluder Abbott and duct occluder 2 are occasionally used too. For short tubular structures with limited landing zones, which type 1, whereas type 2 valve paravalvular leak devices, these are the most versatile of all types. They have faster occlusion and minimizes migration and recanalization, and they're not for short landing zones. Whereas third types they have fastest occlusion capabilities and fix elliptically shaped vascular structures, and their paravalvular leak can also occur with them. Type 4 are best profile, requires only diagnostic catheter for delivery for small and tortuous target vessels and not for more than 6 mm. Important and specific complications of aortic paravalvular leak closures include: 1. Device embolization, which is less than 1%, coronary impingement less than 1%, and prosthetic leaflet impingement less than 4%. 4%. Conduction abnormalities can occur. Mechanical interactions may cause trauma and potential damage during TAVR, leading to tissue injury such as hematoma, edema, necrosis, or compression. These injuries can be transient or permanent, subject to the severity of the trauma. Mechanical injury can occur at different stages of the procedure. First one during the guide wire insertion, during pre-balloon dilatation, valve deployment, or post dilatation. There is an association between aortic stenosis and baseline conduction abnormalities, mainly due to calcium deposits in the conduction system and the development of cardiomyopathy that is associated with the buttonable conduction system. Despite the improvement in the incidence of peri-procedural complications and death associated with TAVR, conduction disturbances, a new onset left bundle branch block, and high degree atrioventricular block requiring permanent pacemaker implantation remains the most frequent complications of TAVR. A new onset persistent left bundle branch block. Studies have shown a wide range of blocks post TAVR ranging from 4 to 65% depending on the valve type. The incidence is higher with self-expanding Medtronic core valve series with an average of 27% and a reported incidence of 11% for balloon expandable Edwards Life Sciences Sapien valve. Clinical impact with left bundle branch block causes ventricular dyschrony that can negatively impact left ventricular function and also predisposes to ventricular arrhythmias. On top of that, left bundle branch block with a very wide QRS interval of more than 160 milliseconds is associated with sudden cardiac death. In addition, it impacts the left ventricular ejection fraction recovery post-procedure in those with systolic dysfunction. The rate of permanent pacemaker insertion. The recent systematic reviews showed that the rate of PPI after TAVR with the new generation platforms ranges from 2.3% to 36.1%. A higher incidence is reported using the self-expanding Medtronic core valve Evolute valve, 14.7 to 26.7% compared to the balloon expandable Edwards Sapien 3 valve, which is 4 to 24%. The clinical impact, the association of PPI with late hazards such as tricuspid regurgitation, infection of pocket complications, and lead dislodgement is well described in the electrophysiology literature. Additionally, chronic right ventricular pacing has direct consequences on the myocardium because it produces ventricular dyssynchrony that can result in adverse LV remodeling and reduced ejection fraction. The strategies to prevent or minimize conduction disturbances associated with TAVR. Cardiac CT is mandatory to evaluate the anatomy and identify predictor of conduction disturbances. Second one is valve selection. A valve should be selected that best accommodates the anatomy and provides the safest profile for each individual case. Precise sizing of the valve is another important aspect to prevent overstretching and mechanical injury to the conduction system or other structures at risk of mechanical complications. A conscious pre or post balloon dilatation is in high risk patients should be a part of the procedure strategy. Newer and refined implantation techniques have been introduced to prevent the impact of TAVR in the conduction system. Indications for heart valve explantation. The failure mode of chronically implanted heart valve can be categorized into four modes. Malposition of the TAVR, unstable or inadequate heart valve position, infective endocarditis, clinically significant thrombosis, and structural valve degeneration other than thrombosis related. This categorization helps with the peri-procedural planning and anticipation of surgical steps to safely explant the heart valve and achieve aortic valve replacement with a good result. Based on the current literature, technical issues with the heart valve implantation or complications thereof resulting in paravalvular leaks is a leading cause for explantation, which accounts for 30 to 40% of cases, followed by structural valve degeneration, which accounts for 20 to 25% of cases, and endocarditis for 15% of the cases.
Okay. This was an extensive, highly technical talk, I should say, because the various hardware, wires, and other things are not very familiar to us as surgeons. It is more of a super specialty field where surgeons are now venturing into interventional techniques. However,
Yes.
I would like to have, I would have liked you to have highlighted on some of the uh, important things that may be required for a surgeon. This entire talk may be not so much involved for the average cardiac surgeon, and especially from your exam point of view. But a few things that you should have highlighted. One was how to choose a balloon expandable valve or a self-expanding valve, and what are the results of the two. Second thing, common sense says that surgical repair of all the complications, most of the things that you have already done an interventional thing, got into trouble, having a complication, and then go back and then try to fix those complications with another interventional technique, like your amplatzer device and VST closure device and other things again, is not going to be very easy or effective. So it is ideal that you should go back and probably remove this valve and put a new valve. That is my this thing. I think that is a common sense approach, but opinions may vary. Then you need to have talked about the explantation techniques, that is more relevant for us as surgeons. How to choose, when to choose, what to do, how to go about explanting a valve, because it's not very easy, especially when supposedly the TAVR was used for a patient who is not fit for surgery. Now you have a problem, and he has to undergo a major surgery in a more complicated situation, and that is going to be more detrimental to the patient than the original selection. So explantation techniques is not easy, because I remember in the olden days we used to have to remove the INSQ Shiley valves, which was a high profile prosthetic valve. One of my consultants in Freeman, who was INSQ's assistant earlier, had to do a lot of these INSQ Shiley valve explantation and put in another valve. So he used to do these things quite often, and it's not an easy thing. And explantation of a previously in valve is not very common. So these are the things that you should have highlighted, especially what you want to do with a complicated TAVR, and how will you as a surgeon get involved in it. Next is how many TAVRs, like Jairaj sir always tells us, what is our own experience? How many
Uh, in,
TAVRs?
in our
How,
hospital in the last 2 years, around 200 towers were done, sir. Of
okay,
which
you
the most common complications was the permanent complete heart block requiring permanent pacemaker insertion, sir, which were around 16 cases, sir.
okay. There were no structural damage,
Structural damages were also
embolization,
there.
nothing. And how?
Embolizations, embolizations, 2 cases were there, sir. And
Uh,
structural damage wise, there were two aortic dissections which have happened, sir. And one, the procedure was abandoned because of the rupture, and they were taken for emergency bent ulcer, ascending aorta rupture.
so you should have highlighted these things, and how many patients required a valve in valve subsequently, how many explantations were done, and what is the alternate once you have explanted a TAVR valve, what will you use to repair that valve, whether you're going to use a bioprosthetic or a stentless valve, or are you going to do a root replacement. These are technical things that you should have known, you should have highlighted on anyway.
Okay, sir.
And again, I reiterate, most of these complications should be dealt surgically rather than interventional technique again. That is my
Okay.
view. Sir, you
Okay.
have got any comments, sir?
I don't know much about that. Only thing is, last time we discussed about the indications of Tavi. Actually, I call Tavi because I'm across the Atlantic in the United States, they all say TAVR. But actually, it's not replacement. You, you're not removing the valve and putting. That's what my concept. So Tavi is more correct term because you're implanting a valve, but you're not replacing a valve. But all over America, it's all TAVR. But on the other side of the Atlantic, British and usually in India, usually called TAVI. Anyway, that's the most common complications. Five most common complications I mentioned in these things are one is annular rupture. The second is ventricular free wall rupture, septal rupture, the complete heart block, then related to the actual valve implantation. The other complications are related to the access site. So you have to decide what should be the access. So it's a CT angiogram to see what is the descending aorta, the tortuosity, the calcification. What about the approach of the femoral? You usually use a common femoral above the bifurcation. That's it. And we used to say it's about the size should be 8 millimeter, but now 6 millimeter is standard size, below which you cannot have the deployment of the valve structure to that. So 6 millimeter. And for a transfemoral, I mean, the first thing to say that therapy should be done only where multidisciplinary team, MDT, is available. That means a good heart surgeon, cardiac anesthesia, radiologist, and cardiologist. And if it's a femoral approach, they don't need general anesthesia. They need an anesthesia standby with proper follow-up, one of those things. Well sedated, and so that is. But if your access is, we used to call transaxillary, but you always said subclavian, and I always thought that transaxillary, but I think every time you mention so, that may be the correct because it's approach to the axilla and the first part of the axillary artery, that's what. But that needs general anesthesia. And if it's transapical, that also needs general anesthesia. And the contraindications also, you didn't mention much. One of the contraindications is the annular size. What is the lower size of the annulus you can hope to do a TAVI?
Sir, in a smaller annular size, they are doing a supraannular TAVI. Sir.
Supraannular TAVI.
Supraannular with say metronic valves is written as an indication, sir.
No,
In a
no,
smaller
no.
annular
The
sizes.
How do
smallest.
they anchor it?
No.
How do they anchor it, supraannular?
The basic principle of TAVI is that the valve should be at least 20% bigger than the annulus because you're not suturing. You are relying on the larger diameter of the valve onto the diameter of the annulus. So the minimum size normally is mentioned 18 millimeter, so that the smallest tiny valve available is 20 millimeters. So in 80 millimeter, you can put a tiny valve. The largest size about 30, and I think you mentioned the largest size of TAVI valve is available. I think they're towards
Yes,
34.
sir.
So
Yes, sir.
and that's the most important thing, the accurate assessment of the annulus and its shape. Well, it's normally rounded or elliptical. And if you undersize the actual annulus and you try to put a much bigger, 20% bigger valve, that's the most common cause of rupture of the annulus. Similarly, if you overestimate and then try to put a valve, paravalvular leak, or even the displacement of the valve is much more common. So, accurate measurement of the annulus, you said in two diameters, is absolutely important. And initially, all cavities were done in degenerative aortic valve disease because degenerative aortic valve disease is usually a tricuspid valve. The valve cups are thickened and calcification is limited, and calcification is limited to the valve cup. Initially, the bicuspid aortic valve is supposed to be contraindicated, mainly because the bicuspid aortic valve, the calcification is
Much
very
more.
much increased, and also the commissures are very much calcified. So the incidence of embolus, cerebral embolus, used to be much more common. And also the patients coming for TAVI in a bicuspid aortic valve is between the 55 and 60. Normally you recommend the American Heart Association TAVI should be done only in people above 65, and Europeans said about 75. The main reason is the long-term results of TAVI. You know what the long-term results of TAVI? Survival. I just read yesterday that 5-year survival is about 58%, and 10-year survival only 20%. So you can't go and put a TAVI in a 65-year-old man, unless of course he has got so much comorbid, comorbidities, and then the other thing is about the expenses. You know what the expense of a TAVI in India?
Yes, sir. 20-25 lakhs.
Yeah, varies about 20 to 30 lakhs. So imagine putting a valve in valve. So that's not affordable in many cases. When the first TAVI was done in India, I just referred and found out that 30 centers doing TAVI in India, and it was done first in 2011. You know that last time the talk we said Alan Kubier did the first TAVI in 2002. In India, 2011 is also. So, and basically, there are two types of valves, you said. The metronic, co-metronic valve, or self-expanding with an ethanol rate. And in that, the latest is Evolute or Evolute Pro use. The Edward Life Science or balloon expandable, the Sapien 3 and the Sapien 3 the series, these are the valves today. And last time you mentioned so many other valves, which are some Lotus valve, which is now discontinued or something. But I read somewhere the Lotus valve produces less of paravalvular leak. So the main 5 complications they say is rupture of the annulus, rupture, free wall rupture of the ventricle, septal rupture sometimes, then cardiac tamponade. Maybe from the pacing catheter because they are all paced at a very high rate, about 120 to 150 beats per minute. So that's rupture. Then displacement, embolization into the ventricle or embolization into the ascending aorta. And most of them needs a good surgical team, good cardiac anesthesia, and good radiology because multi-slice CT, to find out the exact angle and other things required. So then only you can have a successful TAVI.
Why do you think there is a fast pacing done, Navya? Why is it necessary? You must. These are practical things that you should know actually. I'm also not very clear in how and how it is done. You must check with your cardiology.
I think
Uh,
one of the reasons is that one of the reasons I think is because the diastolic time is much
is
less,
less.
and the procedural complication of severe AR may be reduced when the diastolic time is reduced by a fast pace. That's what I think. I'm not sure.
But sir, most of the TAVIs are done for AS. We have not progressed on to AR replacement, I mean TAVIs yet, I think. I'm not too
Yeah,
sure how
yeah.
many are done, but most of it is for AS. And
Yes.
then, so I don't know what is the reason for this fast ventricular pacing.
No, at the time of dilatation, because
Hmm. Yeah.
especially the balloon dilatable things, the sometimes the procedural complications of AR, I mean acute AR. Actually, TAVI was done only for aortic stenosis. Now I think European mild AR is also not a complication. It's not a contraindication for TAVI. So they're extending the indication. Like that, originally it was in a patient very high risk for cardiac surgery by the European Euro 2 or the STS score. Then they reduced it to moderate risk also. But it is a great advancement actually. So many elderly people. Aortic stenosis in the elderly is one of the most common cardiac conditions which require surgery, especially in Western countries. Okay.
Okay. Any other questions? Anybody else?
Have you seen this procedure? I have been curious enough to go and see this.
Yes or no, Navya?
Yes, sir.
You've seen one.
I have not seen one, sir. I've yet to see. I wanted to see.
But you're giving us a huge lecture on TAVI and TAVR with all the technical details. You should have gone and seen one at least.
Not a mortality